Now we are going to start about complement system. In complement system, the protein that are circulating in bloodstream and they can bind to pathogen, especially bacteria. These are a system of hepatically synthesized plasma protein that play a role in innate immunity and inflammation. They are having a various name of proteins that including that like C3, C5, C6, 3A, 3B, like it also having some numerical digits, also the combination of numerical and alphabetical digits like that. First, we are going to talk about one of the important like C3. The C3 is the most abundant complement protein and it is synthesized by liver. It's going to synthesize by liver and it's converted to C3b, that is an active form. C3 in active form that is converted into active form that is called C3b. And C3b binds to bacteria and then it causes bacteria death. The all complement activation involves C3 to C3b. For the all complement activations, we have to need the process for this activation. How it is like C3 is going to activate in C3b and then it will cause the death of bacteria. And they also use one component called MAC, the membrane attack complex. And guys, it's very hard for you to remember all the complement systems, so only remember this part. On the complement system is simply the conversion of C3 into C3b. And for this conversion, we are having three pathways. We are having three pathways: alternative, classical, and lectin. First, we are going to talk about alternative pathway. In alternative pathway, what is going to happen, how the activation is going to happen. So, C3 to C3b. The C3 spontaneously convert to C3b, but the C3b rapidly destroy unless stabilized by binding some components. Guys, the C3 is going to activate into C3b spontaneously, but it will be destroyed rapidly if it did not stable. Spontaneously, it converted, but it is unstable. But when it can attach or bind to some components on its surface, then it becomes stable. And how it will become stable? It can be stable by bacterial lipopolysaccharides, LPS, by fungal cell wall, and by viral envelopes. And there C3b binds amino hydroxyl group and commonly found on the surface of the pathogens. Again, I am repeating, the C3 is converting into C3b spontaneously in alternative pathway. And it is unstable. If it is unstable, it will be destroyed rapidly. But for stabilization, they have to bind with subcomponents on this surface like bacterial lipopolysaccharides, fungal cell wall, or viral envelope. The C3b stable can be bound by complement protein B, and complement protein D clips B bound to C3b. And the forms, like what is happening, I will mark a diagram for it. It is unstable, okay? For example, the C3b is going to bind with bacteria LPLS. It is not stable. When it will be stable, it will going to bind with some complement proteins like B and D, the protein B and D, and then it will convert it into one form that is called C3b, that's it, and C3b, capital B and D. And it is act as, it will equal to C3 convertase. C3 convertase, and this enzyme result in stable C3b can give more C3 to stable C3b. What is happening at one time only? One C3b that becomes stable by joining any pathogen components, then they will be binding with the protein B and a D that will make a component C3b and Bt that will equal to C3 convertase. They are having the function to stabilize or convert C3 into C3b more. Like if there's a more C3 is present body, they will also going to convert in C3b by having of the C3 convertase enzyme. It is just like positive feedback. How? Like it will be activating increasing amount, it will be stimulate that enzyme and that will go and increase the amount or more. Okay. It is all about the alternative pathway. The alternative pathway is just spontaneous conversion. The alternative pathway is just spontaneous conversion. Understand? Now we are going to move to our next pathway, and next pathway is the lectin pathway. Next pathway is lectin pathway. The lectin pathway is simply the mannose binding lectin. Mannose binding lectin. The mannose is present in most of our microorganisms, and that this mannose binding lectin is produced by liver, and from the liver it is going to blood and tissues. Why it is attaching a binding of mannose? The mannose is a component of many microbes. It's a bind surface with the mannose that present in many microbes, and it circulate with MAPS. Is it going to circulate with MAPS? The MAPS stand for mannose associated serine proteases. Serine proteases. And they will, what they will do, they will cleaves, convert that C3 into C2b, C4 into C4b, and then they will be joined together. The C2b and C4b is joined together and make one enzyme C2b and 4b joined together, and they will make enzyme. Already you know in the previous pathway line that C3 convertase, that is totally equal to C3 convertase. And what is going to do? They were again going to activate C3. They convert C3 into C3b. Understand? This is our second pathway. The first one, alternative pathway, in which the conversion is going to spontaneously. The second, the lectin pathway, then it's happening by the mannose binding lectin, and in which we are cleaving C2 and C4 in 2b and 4b and making the enzyme CT convertase that doing the same step, converting C3 into C3b. Now we are going to a third pathway, and you guys know our third pathway is a classical pathway. The classical pathway is a classical pathway for the conversion C3 to C2. What is happening? They will use antibody-antigen complexes. They are using antibody-antigen complexes, and they will bind with C1. They will going to bind C1, and they will cleave after binding C1. They will also cleave C2 into C2b, C4 into C4b, and the same thing will happen. The C2b and the 4b will equal to and going to activate and make like C2 activity like C3 convertase And what is the function of C3 convertase? They will converting C3 into C3b. Understand? Again, there are three pathways for the activation of C3. First is alternative, second is lectin, and third is classical. In the alternative, they are going spontaneously. In lectin, there is a mannose binding lectin, and in classical, they are using antibody antigen complexes for the activation of C3 into C3b. And what are important enzyme? C3 convertase. That is understand for you guys. Hope so. And we are talking about C1. The C1 is a large complex. We talk about the C1. The C1 is a large complex. And we try structure. It having a structure of C1Q. Okay. Having a structure of C1Q, C1R, C1S, and having one C1 inhibitor. Is a structure. Normally it is inactive due to C1 inhibitor attached with it. But it must bind to two FC portion close together for the activation. What we're going to happen, for example, if there's know about the IgM, it having 5 sites for binding with the antibodies. Like it's 1, 2, 3, 4, and 5. Structured like that. Understand? And you guys also know there is a lower part, the FC part. The FC region belongs to complement binding. Complement binding. So if the two FC bindings are close to each other, okay, the C1 is going to bind with them and they are too close to each other, then it will be going to activate. And by that, the C1 inhibitor will fire off and it will activate. How? Because the inhibitors are removed and fall off, and then the C1R and C1S become more active or active, and they will also create same thing, C3 convertase. And what is happening for them? In which pathway it is happening? It is happening in classical pathway. Classical pathway for the activation of complement system, in which we are using antibody antigen complexes. Understand? Well, we were talking about the activation by spontaneously they will attach and staple in alternative pathway, where how our own body cells, how the host cells are protected from the C3b. It is protected by one factor and its name as factor H. What is going to happen is the factor H? The factor H is a plasma glycoprotein also synthesized by the liver, and it blocks the alternative pathway. On host cells. What is happening in alternative pathway? The C3 is converting the C3b spontaneously, and it is unstable. To getting stable itself, it needs some components. I'm right? It needs some components like amino or hydroxyl group that also present in host cell, but host cell protect it by some factor, that is factor H. And what is it doing? It accelerates the decay of C3 convertase. Factor H is going to accelerate decay, decrease the amount of C3 convertase, that a more common component for the conversion of C3 into C3b. And secondly, it cleaves and inactivates C3b itself. Like that. No entrance for the host. Used by the cancer cells, exactly haven't no, like for example, if I am a doctor, I a medicine for film component, I also know how to use and how it will be outcome for when I have to use to protect myself. And now this thing, the factor H mechanism is also going to copied by our enemies. Who are our enemies? Like cancer cells and some bacteria. They know the secret of factor H, and these also taking and adopting the same mechanism to protect themselves from C3b. You guys saw the complement. What the complement system doing? They are destroying the bacteria. They're destroying the neoplastic cells. For the protection, they are now again they are also using the factor H that the host cells are using to protect themselves. The same mechanism is also using by cancer cells and bacteria to protect themselves from C3b and allow the evasion of alternative pathway. And the key pathogen that mostly used that H influenza that they are using, that are H influenza and meningitis and many of streptococci and pseudomonas. You guys also know about C-reactive protein. C-reactive protein, and it is also acute phase reactant. It's acute phase reactant, and it is also synthesized in liver by the stimulation of interleukin 6 that is going to released by macrophages, and it will bind to bacterial polysaccharides. The CRP also going to bind bacterial polysaccharides, and it activates the early classical pathway. We already done with the C1. If you guys know, we already done with C1. It is a large complex. It also activates the early classical pathway. Because now I'm just talking about a CRP because it's also having some activation role in the complement system. They also activate early classical pathway by the help of C1 binding. By then they will consume C3, C4 and also generate what will be generation? C3b as always, also working mink. It does not active the late pathways, and you guys know what are the late pathways? The late pathways are C5 to C9. Understand? If we summarize that on, well, the C3A and C3B, the C3 is converted, goes to C3A and C3B. The A also acts as an anaphylatoxin, that in which it will be histamine release. Histamine is going to release from mast cells, and it will be increase the vascular permeability. It will be going to increase vascular permeability. It's a function of C3. It is also an act on anaphylaxis reaction, and it releases the histamine from the mast cells and increase the vascular permeability. And C3b is going to work when the membrane attack complexes for the death of bacteria and also for the opsonins, for the phagocytosis of bacteria. Opsono. Okay. And further, the complement system, if we're going to repeat again, already we done that. What is that? The complement system, the C3 is going to convert, the C3 is going to convert into C3b by three pathways alternative by lectin, the mannose-binding lectin, and classical. Classical, which one component important? C1. Here, MBL. And it is spontaneously. Understand? And by activation, they are going to kill bacteria. But here, it is also using one component, that is MAC, the membrane attack complex. The MAC, membrane attack complex, is stable by the stable C3b that lead to formation of MAC, and the MAC form, it is a form from the formation. The mainly formation of MAC is done by C5, 6, 7, 8, 9. Or in early or easy words you can say it with the late complement. Late complement components. And how they will go, the C3b and A fragments, they will cleave the C5 into 5A and B, and also C6, 7, 8, 9, they will together and go and make the MAC, membrane attack complex. How will it going? The bacteria cell will going to swell and burst. The one more important point regarding that complement, you already know the MAC is going to form by C5 late by the terminal complement or late complement C5 to C9. The C5 also activate into C5A and C5B. The C5B is going to help in formation of MAC, and A is also having the same function like C3A, having anaphylatoxin, helping anaphylaxis action. But the C5 having one more important work. Also it's an anaphylaxis, but it's a very major neutrophil chemotaxis. Neutrophil chemotaxis. It is the VIP taxi of neutrophil. Don't forget. C5A is the VIP taxi of neutrophils, on which the neutrophil will sit and say, you guys, hi, I'm coming to healing you, and starting the inflammation. Jokes apart, all the things done, we are done with all the things like C3 is converting to C3b by the help of alternative pathway, lectin pathway and the classical pathway. By this, they will going to kill bacteria by using the membrane attack complexes, and that membrane attack complex is formed by C5 to C9, and also by here there are two more components, C3 and 5A, that is going to help in anaphylactic reactions, and 5 is for neutrophil chemotaxis. Understand? Inhibition of complement. How the complement system going to inhibit? How the membrane proteins protects the human cells? There are also a big question. How our own heart cells, our own body cells are going to protect from the membrane protein? We are having two type of proteins that going to help us to protect from the complementary system. Decay accelerating factor, also called DAF, and second name is CD55. Our second one is MAC inhibitory protein, also called CD59. One is decay accelerating factor, and second is MAC inhibitory protein, CD59. That DAF disrupt the CTP attachment. Like the surface, the binding surface on which the C3b have to come and attach, the DAF will go and destroy all the attachments from the cells. And the 59, CD59, the MAC inhibitory proteins also disrupt the membrane attack complexes to protect our own cells, and a special protein for the protecting RBCs. And these proteins specially going to protect RBCs in deficiency of DAF or 59 lead to hemolysis. Automatically, it's a simple thing, like these both components are going to protect RBC. If we having a deficiency of DAF and CD59, we are having deficiency. There is nothing that is going to protect the RBC from the complement system, so it will be acting hemolysis. And this one disease we will talk at it as paroxysmal nocturnal hemoglobinuria. It's also like that. In that disease, what is going to happen, that is paroxysmal nocturnal hemoglobinuria, which due to that factor the RBC lysis, and due to this RBC lysis there will be anemia, the first thing you guys know, and second there will be free plasma hemoglobin, and can cause the thrombosis. And secondly, we are also having the hemoglobinuria. And that hemoglobinuria can be lead to renal failure in that patient. And secondly, that RBC lysis going to produce free plasma hemoglobins, and these plasma free hemoglobins go and bind with nitric oxide. And due to nitric oxide depletion, like all the nitric oxide is going to binding with hemoglobinuria, and due to this there will be depletion in nitric oxides. Then depletion of any is going to cause increase in smooth muscles tone, and that will activate erectile dysfunction. In cause erectile dysfunction can also cause dysphagia and also abdominal pain. This all can be things happen due to paroxysmal nocturnal hemoglobinuria. Paroxysmal internal hemoglobinuria. The paroxysmal nocturnal hemoglobinuria is a classical causes sudden hemolysis at night. Classically, hemolysis at night. And having the fatigue, dyspnea, it is so totally the features of anemia. And secondly, having the abdominal pain for the smooth muscle tension, and thrombosis. The main thing, thrombosis, that is the main leading cause for death, and usually venous clots, and having unusual locations like portal, mesenteric, in cerebral veins. We are also having a more disease, that is inherited C3 deficiency. Inherited C3 deficiency. The inherited C3 deficiency recurrent infections. You guys know that C3 is what C3 is going to do. C3 is going to C3b, and C3b is going to destroy bacteria. If there is a deficiency of C3, there will be high risk of recurrent bacterial infection. And most common are encapsulated bacteria like pneumococcal, Pneumonia begins in infancy. The immune complex deposition also there. The immune complex cleared when they bind companion. Antiseptic immune complexes will also going to deposit the membrane because immune complex clearing will decreases. It only clears when they are going to bind with complements, and macrophages have complement receptors. C3 deficiency cause glomerulonephritis from immune complex deposition, and other type 3 hypersensitivity syndrome can happen. Very important points. It also can cause hypersensitivity. Type 3. When they are going to cause? When there is a deficiency of C3, because due to it there will be decrease in clearance of immune complexes and they will going to deposit in membranes like that. Understand? Secondly, if we talk about late complement system like deficiency of C5 to C9, like terminal complement pathway deficiency, like C3 impaired. If, for example, there is a deficiency of C3, then there will be more radicalization, more destruction in the body. But if C5 and C9 deficiency is there, but still in our human being body, there is C3. So C3 will compensate the function of C5 and C9, and they are less severe disease than the C3 deficiency or early complement deficiencies. Like C3, impaired defense against encapsulated birth, they still have C3, so anaphylaxis, they are also having C3b, so opsonins for macrophage is still there, guys. What I am going to say about the late component of terminal complement pathway deficiencies is that still in that body C3a is there. That is responsible for anaphylactic reaction. The same C5 is doing. If there is not C5, so C3a will do. No issues. Yeah, also C3b, they also need opsonin and bacterial destruction. But there's a recurrent, according to researchers, there's a high chance of recurrent infection of Neisseria. That Neisseria will do, Neisseria infections will do this, and often meningitis. And if you are going further, it's all the things also written in books saying first we have to go here thoroughly like system of hepatically synthesized plasma proteins that play a role in innate immunity and inflammation. Having a membrane attack complex, the defense against gram-negative bacteria, and you guys know membrane attack complex is going to make by late complements. What is it? Let's go through from the book. If you go through from the book, they say the system of hepatically synthesized plasma protein that play during innate immunity and inflammation. The membrane attack complexes defend against gram-negative bacteria. You guys know the membrane attack complexes is made by C3b or formed by late or terminal complement system. The CH50 is used to screen for activation of classical complement pathway. Disadvantage, I will elaborate it more deeply. The CH50 is one is there to detect the complement system. Like in that, the patient serum is added to sheep RBC. What is happening in CH50? The patient serum is added in sheep RBCs with antibodies. And there's the classical pathway. Which pathway? Classical pathway, and it needs all complement factors for normal results. And the serum is with the RBC, with the antibody, then it will detect all the things normal or not. It's normally done for the hypercomplementemia, and the normal range for that is 150 to 250 units per milliliter. Until they detect the C3 or C4 level low in many complement-mediated diseases and lupus and lupus nephritis, and there's not been point of recurrent nephritis and post-streptococcal recurrent nephritis again. Already they mentioned right there the CH50 test is used to screen for activation of the classical complement pathway. The classical complement pathway is working right or not. Then there is the activating pathway. You guys already know there are three pathways: classic, alternative, and lectin. Classic, there will be antibody antigen complexes are going to activate. In alternative, spontaneously they will activate. And lectin, they will mannose binding lectin. Mannose are the sugars on microbe surface. The functions: C3b opsonization, C3a 5 and 4a going for anaphylatoxin connection. 5A also do neutrophil chemotaxis, and C5b9 is for the MAC or cytolysis, the destruction of cells. The C3b binds to lipopolysaccharide on the bacteria. MAC complex is important for neutralizing Neisseria species. And deficiency results in recurrent infection. Also, guys, you guys know in the late also. Already you guys know that the MAC is stimulated by C3b. When MAC is going to formed by late complement system works from C5 to C9. So in C5 to C9 deficiency, the most common issue is a recurrent infection of Neisseria species. And this is in the morning, they get nice big bag from 5 to 9 p.m. Opsonins are C3b and Ig are the two primary opsonin bacteria defense, and they enhance the phagocytosis. The C3b helps to clear immune complexes. So deficiency of C3b is going to increase immune complexes. In disease in which there is a deficiency of C3, there will be decrease in clearing of immune complexes, and there will be resulting deposition of immune complexes, and they can cause a lot of diseases like proliferative glomerulitis and etc. And like there's an inhibitor decay. Inhibitors are used for protecting our own human being cells to stop the action of C3 or the complement system, or attacking a complement system on their own human being cells. So we are having the decay accelerating factor, DAF also called CD55, and C1 inhibitor forming C1 esterase inhibitor help prevent the complement activation of cells like RBCs. So all the pathway you guys already know. Like from the C3, there will be C3b, and they will going to activate further. You guys know alternative, spontaneously. In classic, there is antibody antigen complexes going to convert C3 into C3b, and lectin, they have mannose binding lectin, like that. And most important enzyme is C3 convertase. They are giving the complement disorders like LD complement deficiency, high risk of severe recurrent pyogenic synapse and respiratory tract infection, and they are cause the clearance of antibody antigen complex in high risk of SLE and hypersensitivity type 3 reactions. And in terminal complement deficiency, there is increase in susceptibility to recurrent Neisseria bacteremia to decreasing MAC. And C1 inhibitor deficiency causes the hereditary angioedema. This is a very important topic. The hereditary angioedema is due to deficiency of C1 inhibitor protein and many functions beyond the complement system. What they do, they will break down bradykinin vasodilators, and deficiency lead to a high bradykinin level. What they are going to do, they just like that. The C1 inhibitors protein are going to break down bradykinin. But due to deficiency of C1 inhibitor, there will be increase in bradykinin in the body, and bradykinin is the vasodilation. And this deficiency leads to high bradykinin level, and that will give the episodes of swelling and edema. And they also have the recurrent episodes of swelling without urticaria, and it begins in childhood. Swelling of skin, GI tract, upper airway, and airway swelling can be fatal and is diagnosed by low level of C4. And it lacks C1 inhibitor and a consumption of C4. And why the C4 instead of C1 inhibitor? That human consume C4 in a high amount due to in serum will find low C4, and it can be treated with C1 inhibitor concentration. But there is a very important clinical association in these patients who are having deficiency of C1 inhibitor. We can't give them AC inhibitors. The AC inhibitors are contraindicated because already in that patient bradykinin level is very high. If we give the AC inhibitor, then we'll be increasing vasodilation and patient can be fainting and it will be lead to death of the patient. So AC inhibitors are contraindicated in patient they are having the C1 inhibitor deficiency. So Paroxysmal Nocturnal Hemoglobinuria, defecting PGA gene that prevents the formation of glycoside phosphatide inositol and cover complement inhibitors such as decay acetating factors. Already we know about that. We are having some inhibitors like DAF and C1 esterase inhibitors, CD55 and CD. We are having CD59. We are already done with that. That will protect all the things, but due to deficiency of that, then that complement system going to act on RBCs and it will lead to hemolysis. We already done with that thing. So what are complications? Mainly that complement with the intravascular hemolysis, they will decrease haptoglobin and cause dark urine and can cause atypical venous thrombosis, Buercher syndrome, portal vein, cerebral or dermal thrombosis. For the treatment, we are going acozilimumab, the anti-C5 antibody, inhibits the terminal complement system and MAC formations. This is all about the complement system. The complement system, the important thing you have to remember, but the pathways and the main conversion of C3 to C3b and what a deficiency lead to the early complement or late terminal complements.